through OSU Medical Center Graduate Medical Education. A disclosure statement has been signed and is on file with Graduate Medical Education Office. Dr. Janell Largent is an OSU alumni and duly boarded in family medicine, neuromuscular medicine. During her training, teaching and OMT persisted as a significant interest and source of fulfillment, prompting her to return to her home state where she's able to join the OSU CHS OMM department as assistant clinical professor. She has since become the second year course director and just recently the assistant program director for the OMM residency program. The Cloud CME activity code for today's grand round is 2252. Please welcome Dr. Janell Largent.
Okay, thank you, Dr. Ty. I am so sorry for the delay, everybody. True to form, Dr. Ty said when I first started teaching here that I had to have an ENP field around me. So I'm holding true to that title that was awarded to me. But thank you so much for having me here today. I'm excited to talk always about OMT. And so to try to make your time useful, beneficial, and hopefully a little bit fun, we will go ahead and get started. So first item of business is that I have no disclosures. So very quickly we get that taken care of. So we can move on to seated and treated utilizing OMT in the patient encounter. Yeah. So our objectives for today are to discuss some sample clinical presentations that are likely to benefit from OMT and OMT that is accomplished in a seated position. So to do that, we're going to review a few different steps in those treatment techniques and maybe a few tips and tricks to try to optimize that OMT effectiveness. Hopefully after today, we fostered some comfort in incorporating OMT when maybe there was the thought that we couldn't use OMT in a certain patient encounter. So commonly we'll come up against those things that will make us think that, and some of those are that maybe we don't have an OMT table, maybe the exam room is a small exam room, or there's not a lot of room to maneuver because there's other equipment or furniture in the room. We also have a lot of patients that for different reasons, they can't be in one position or another. And of course, we always have time as something that we're being conscientious of. So regardless of what it is that may make you think that we can't do OMT, there are some ways that we can address those issues. Well, we can't address all of them, hopefully by treating a patient in one position, and hopefully the position that the patient is already in, we can help facilitate using OMT and not see it as another barrier. So today when we're talking about our treatment techniques, I just want you to keep in mind that there are so many clinical scenarios where this OMT technique might be beneficial. Obviously, we cannot go into all of them, and we can't go in depth into each of them either. So our discussion points are going to be talked about briefly so that we can have a more focus-driven talk today. So for our first technique, we're going to talk about a few different scenarios, and we'll talk about what the technique is after those clinical scenarios. So when I think about a patient with an asthma exacerbation, the first thing that comes to my mind is increased respiratory effort. So we have the recruitment of those accessory muscles. So we think about that lengthening and shortening of those muscles, the hypertonicity that's constantly going on. And it makes sense why there might be rib pain, especially if it's with a cough variant of asthma. So that's something that's a little bit more obvious when we're thinking about an asthma exacerbation, but also there are times when there's a subjective worsening in symptoms without any noticeable or measured change in our lung function. So it's one or a few different reasons as to why we might be thinking about OMT in our patients with asthma. Moving on to our next category or clinical scenario would be an exacerbation of CHF. And regardless of what the EF is doing, if we're thinking about any increased volume or preload leading to lymphatic stasis, we're thinking about what we can do to improve that. And so while that might be an early indicator, when we start getting into the point where we're having more pulmonary edema, I really start to think about addressing any sort of structural issue that's preventing optimization of our euvolemic state. Another category would be your good old-fashioned sinusitis, whether it is viral, bacterial, secondary, whatever it is, your favorite version of sinusitis. We're still going to have some symptoms that we can address with OMT, whether it's headache or eustachian tube dysfunction. We can start to focus on, again, making sure that we are addressing those structural components that may be contributing. So what area would we be working on? We would be thinking about the thoracic inlet. And so I'm not gonna, if you like the thoracic outlet, then you can go with thoracic outlet. I'm just here to remind you right now that for our true definition of thoracic inlet, that we're thinking about T1 through 4, ribs 1 and 2 and their costal cartilages, as well as the manubrium. And then while not technically a defined component of the inlet, the proximity and the involvement of the fascia in the area absolutely can play a role. And so when we think about the function of fascia, it's there to provide support and stability to maintain the body in the production of motion through its properties as a connective tissue, with its properties of irritability, contractibility, relaxation, distensibility, and elasticity. So if we're thinking about the structures that are moving through the inlet, there's different systems that we can think about that we would also be impacting. And so when we think about T1 through 4, all my students know that I always think a lot about the visceral somatics. And so we are right there with the sympathetic chain ganglia, and we can be affecting not only the heart, but the lungs as well as the head. So we can definitely hit some sympathetic involvement. Contrastingly, while it might not be my favorite place to address any parasympathetic or vagal concerns, we do have to mention that it's moving through this area and there can be some indirect effects as well. Here we can start to see the thoracic duct that's coming through just behind that internal jugular vein near that subclavian. So we can see that thoracic duct. So we're moving on to our lymphatics, which is a much more vast network than sometimes we think about. Here we can see a little bit better where we've got the thoracic duct coming in just by the subclavian vein. So again, you can see where the fascia and the different structures that are nearby can be possibly restricting that. And then when I was preparing for this, I found this slide, I found this picture, and I really enjoyed it just because you can see the continuity between the sigmoid sinus through the internal jugular all the way down to the subclavian. And so it's really nice to see the corresponding, if there's any corresponding vascular congestion there. We think about headaches, we think about doing our venous sinus drainage. Anytime we're doing that technique, it might also be beneficial to address the thoracic inlet. So how might we address that thoracic inlet? We can address it with a myofascial release. So when we're thinking about a myofascial release, anytime we're doing that, we're asking the physician to engage the tissues so that a direction of ease or restriction can be appreciated to determine the position as indirect. And so when we're thinking indirect, we're thinking away from restriction. We also call this ease or direct, which is going into resistance, and we talk about this as bind. So this should be a more common way that we think about the thoracic inlet with the patient supine, where we have our thumbs resting on our upper thoracics and then our fingers looking at the first and second rib. So having a finger above and below the clavicle near that manubrium so we can monitor as much of that inlet as possible. We like to stack our planes when it comes to myofascial release. So if we're thinking about 2 to 3 planes that are included, it often will help facilitate the effectiveness of our treatment and also helps with time efficiency as well. So if you think about AP, if you think about clockwise and counterclockwise, and then also some inferior superior movement. And so you might think of this as more of a side bending type motion. And when possible, typically we want to stack those so that we're using all direct or indirect directions. And then for myofascial, we're just usually holding that tissue until a release is observed. So for treating in a seated position, I really do like the thoracic inlet. I find that it very closely correlates to your supine treatment. And so for the seated treatment, your hand placement is really going to be in the same place. You're still going to be stacking and holding that tissue until you find a release. I think the learning curve here for the thoracic inlet is to play with the amount of force that you use to engage the tissues, making sure the patient is stable, and so that as you are moving the patient in a direct or a indirect stacking manner, that they're keeping themselves upright in their line of gravity and they're staying comfortable so you can get that tissue to release. So I think this is most easily accomplished when you're able to stand behind the patient, whether they're seated on the table, on the hospital bed, but oftentimes I'll do this even if they're in the chair. You can stand behind the chair and still get a really nice thoracic inlet release for them. So while you're doing this, a couple little additional pearls for you is to remember to use a respiratory assist. There's a lot of unconscious relaxation that can occur, and so it can help improve your inlet release with very little effort. As you practice this, as you do this more and more, you'll start to pick up on restrictions that are more caudal. And so you can actually start to work on some of those as well. But as we move more caudal, sometimes you have to increase the degree of motion that you're using to reach your restrictive directions or your indirect directions. So just keep in mind that you want to keep that patient comfortable. And of course, anytime we're doing a technique, we always want to talk about any contraindications. So some very straightforward contraindications would be if there are any fractures, if there's any open wounds, those are pretty obvious. But the other thing to think about is if there's infection or abscess there, can weaken the tissue surrounding it. And so where we're directing our treatment, even if it's not directly under our hands, we still want to be cognizant of the forces that we're putting through the tissue. So there's a lot of relative contraindications as well, but we won't go straight into those. So for our next technique, we've got some more clinical scenarios. First of which is a cervicogenic headache. And we won't go too far into headaches because it's a very expansive topic. But a lot of times there's discomfort with motion. And this is generally if there's a reproducible or localized source of the pain. This can be identified or confirmed by your imaging results as well. And so if there's that cervical region or etiology that is contributing to their headache, there's often a structural component that we can address. Not always, but a lot of times. Similarly, there are some cases in which there can be an upper extremity paresthesia, usually in the setting of a mild foraminal stenosis. We're not talking to the point where we've got change in DTRs or weakness, but a lot of times there's almost a pseudo type of a paresthesia where it's coming from a spasm of one of the muscles as well. So whether it's just a mild stenosis where it's exacerbated by positional restriction or dysfunction or spasm of a nearby muscle, you can have some paresthesias that actually resolve with treatment. It's very, very satisfying to see. So sometimes if you think that this is what's going on, you may be able to do your neuromuscular exam before and after and see some surprising and fun changes. So improvements for those changes. Additionally, there's procedures or events that sometimes can create some neck pain. So if we've had somebody with a lot of different lines and have had difficulty, so we've really had to limit their motion, so they can have some secondary issues after intubation, extubation. Sometimes they'll complain of things or they've been held in one position a long time with imaging. So a lot of times with those, you can get some reduced cervical motion that can easily resolve with some treatment. And so what treatment would we be talking about here? We're going to be talking about some cervical muscle energy. So again, any fractures, we're going to stay away from muscle energy. The other thing to think about with this is if you're ever putting somebody in a treatment position and there's reproduction of symptoms, like worsening with paresthesias, that would be something that we would want to stop and assess further. Anytime there's any risk of relative contraindications, I would always ask that the benefits and the risks be clinically discussed and decided upon before any treatment. And then if there's ever a absolute contraindication, to defer treatment, such as a neoplastic process in the area directly being treated. So with cervical muscle energy in general, as a reminder, is a direct treatment where the provider is placing the dysfunction into the restrictive barrier and allowing there to be an isometric muscular contraction away from the restrictive barrier, and that's via the patient effort. And so below we've got some example of dysfunctions for our various levels of the cervical region. So keeping in mind that C2 through 7 are type 2-like, so we have side bending and rotation in the same direction, and then our atypical with our OA, where we have side bending and rotation opposite directions, and just rotation with the AA. So where diagnosis is almost always for our position of ease, same is true for muscle energy. So when we've got restricted motion translating from left to right, and you can visualize this with your patient supine right now, where it may be more common for you, but if you're translating from left to right in flexion and you have improved motion in extension, there's reduced side bending to the left in flexion and preference or ease of side bending to the right extension. So your diagnosis would be an extended side bent rotated right, as that's where there's the greatest ease. And so as we've been going through these slides, we've been going deeper and deeper into our muscle layers, just as a reminder that we're really focusing on those rotator muscles that are quite small. And so you really just need some very gentle motion and not a lot of it. So you can really localize well and utilize those small muscles. So when we take cervical muscle energy and we use it in a seated position, the procedure is still going to be the same. So we're going to localize to that segment. We're going to use our flexion and extension. We're going to make sure that we're adding side bending and rotation localized to that segment, and then our muscle energy effort with 3 to 5 seconds, 3 to 5 times. So for a seated screen, sometimes this is the more difficult part of using cervical muscle energy. And so I like to think about doing a cervical screen in 3 different portions. So if we have an upper portion and then translation, middle portion of the cervical area, and translation with our lower portion of our cervical region with translation. I break it up this way just because sometimes there's a lot of cervical lordosis, and so it allows me to be a little more specific without breaking down into a full segmental screening, and saving that just for when I found one of the 3 that's more restricted, then I can tease out the 2 or 3 vertebrae there to find where the restriction really is. But say I found a restriction here and we didn't want to translate from left to right. So our diagnosis, we've talked about briefly, and I'm not going to go too far into detail there. So we've got an extended segment rotated to the right because it was worse for her when she was in flexion. So our treatment position is going to be just like it would be when we have the patient supine. The thing to watch here is to make sure that we're localizing to that segment. We're not allowing excessive extension or flexion past that segment, which is sometimes easy to do. So we'll still use our 3 to 5 muscle energy efforts 3 to 5 times. And that's cervical muscle energy while you are seated. So for our third technique and our clinical scenarios for that, we have pneumonia. So a lot of times with pneumonia, there is this unrelenting rib pain that is very frustrating to patients and sometimes difficult to treat because it tends to stick around throughout the duration of the pneumonia, but sometimes it doesn't resolve after the pneumonia. Sometimes you'll also see an increased oxygen requirement, or maybe it's taking longer to taper your patient than you would expect. And that often can go along if there's some corresponding dysfunction with the ribs or surrounding tissues, diaphragm and such. So sometimes you will have a patient where you'll know what their lung function has been, and they're not performing quite where they would be. So that would be another indicator that maybe you have one of these other things going on with the prolonged tapering or just a slow resolution. Musculoskeletal chest wall pain. There are so very many possibilities. We're just going to stick with these brief two that are the most common. We see a lot of chest pain that we need to rule out any cardiac involvement with, but then after that's done, we can really take a look and make sure that there's nothing structural going on that we can address, and post-surgical as well. So I've seen in any post-op CABGs or anything else where there is potential for rib sternal involvement there that can be addressed before we've had a dysfunction really solidified in that post-surgical state. I see a lot of shoulder pain that has a normal shoulder exam, and then we realize that and then we realize that through all of that, it's not actually a shoulder issue, and it's a surrounding issue by the rib typically. And so a lot of times we see that with athletics. We see it in patients who have overuse injuries or some structural issues that sets them up for some rib dysfunctions. So we're going to talk about some BLT in the rib area, and the thing that I would ask you to think about here is that we've got some posterior rib angles back here, and then we're usually thinking about hand placement still on the rib near these costal cartilages. So as a reminder for BLT, it's an osteopathic treatment method which involves minimization of periarticular tissue load and placement of the affected ligaments into a position of equal tension in all planes so the body's inherent forces can resolve the dysfunction. So we're thinking about ligaments and we're thinking about equal tension, hence our wonderful name of BLT. And yes, this is the technique that is similar to LAS. We're going to just focus with BLT for today for simplicity's sake. So our general steps for BLT are to disengage with either compression or traction. And we're going to then exaggerate. Usually that means exaggerating the diagnosis because we're moving towards ease. Again, we're moving towards ease, not all the way into ease. And then we're going to maintain that place of balance where tensions are equally balanced. So when I'm talking about balance, I'm really looking for both or all ligaments that we are assessing to be in a state where they are equal to each other. So in the bottom, if this rubber band with a knot was showing that we were at a neutral state, that our tensions were equal on both sides, then the rubber bands in a Y shape above would represent a dysfunction that has moved that neutral, it's moved that position of ease to the right. And it's done this because there's increased tension with these two different bands. So you can think about a strain that's pulling into an adjacent area. So we've got increased tension on this other side, or maybe on the left, on the other side of this, there's less tension. And so by trying to adjust your technique so that you can then achieve a balanced tension on both sides, this would be moving towards our ease. This would be allowing those tensions to be more balanced. And so once we reach this place, then we're going to hold that until we feel the softening of the tissues. Keeping in mind that we always have additive force vectors. And so sometimes you may not have the exact motion that you think, or maybe you need to exaggerate one more than the other. So this is just a little demonstration of balanced tension for BLT. So balanced ligament tension with ribs is often done supine, but it's very similar again with being seated. The challenge with using, I think the challenge with using BLT while seated is not the treatment itself, but it's the screening. And so because you can have reduced excursion of the ribs posteriorly, I would focus anteriorly. And so just practicing this beginning out, I would actually encourage you to confirm that with a supine screen as well as a seated screen until you're comfortable with that. And so you would be always talking to your patient. I usually just say, I'm going to screen your ribs and I'm going to start underneath your clavicles, between your breasts, and on your sides. And then each time I'm placing my hands in an uncomfortable position, I always ask the patient if that's still okay, because sometimes there's still miscommunication even with our best intentions. And so as a reminder for which rib we will be treating, we still have the wonderful bite mnemonic, which helps us to remember that for any inhaled dysfunction, we're going to be treating that bottom rib. For an exhaled dysfunction, we're going to be treating that top rib. So for our procedure, I'm going to go ahead and move on to where we would do this for a seated position. So we would have our thumbs placed in the mid-axillary line, and we would have our hands on the posterior rib angle and then making good contact on the anterior portion of the same rib. The first part of BLT is disengagement. And so my favorite way to reach disengagement for BLT is to actually have the patient lean into me. And so you can use compression or traction, but this allows for compression to be utilized in a way that the patient can provide so that you're not pushing into them, because some patients will take that as a cue and move further away from you, and then you don't have to chase them across the table. So allow them to come towards you, and you can always have them move back and forth a little bit, or then you can adjust so that you get just enough compression to disengage. We're not overly compressing, and then we've lost our disengagement. So disengagement with our compression, and then we're going to exaggerate that ease. We're going to find the position where that rib wants to move, and then we're going to hold that. So for an inhaled dysfunction, I often find that the rib wants to move more in an inhaled direction. So my posterior hand will move more inferiorly, my superior hand, or my anterior hand will move more superiorly, and there's usually some rotation with that as well. So again, we're always holding that technique, holding that treatment position until we feel softening and rechecking. So BLT is a little bit of a longer technique, but it's really, really nice, especially for patients who are very tender or maybe have some limited mobility. So things to remember with BLT, yes, I still think of the sandwich every single time I think about it. But my tip for that, the first one would be that you not go as far into the direction of ease as possible. I think this is something that's very easy to fall into because we're thinking about all of the different planes, and it's hard to sometimes keep all of that in the forefront of your mind. So if you have to go as far as you can into ease, just to find what those three directions would be, I would then ask that you start back over and then go slightly into that barrier or into that direction of ease. I apologize, direction of ease. And so as you add, then you can stay where that tension is balanced. Sometimes, not commonly, but sometimes when you're in that position of ease, there's that rare wobble. So that's our buzzword we hear so much about. And it's really just a repositioning of those tensions. And so sometimes you need to reposition just a little bit. Sometimes you can hold on to that treatment without repositioning, but it's not a bad thing to reposition. Also with BLT, sometimes inhalation and exhalation can play a surprising role in that treatment position. And I remember when I first started learning about that, it seemed so minimal to me that I didn't always include that. And actually, just incidentally, with a patient's respirations, found that as they were breathing in and out, that it actually changed my treatment. And so being intentional with that and just testing to see if it really is better when they take a big breath in and hold or exhaled can really help your efforts. And we already talked about the patient helping with positioning there. So for our fourth technique, on our clinical scenarios, we have pelvic floor dysfunction and coccydynia, a topic that is actually very difficult and difficult to treat and sometimes frustrating for both us as the provider and for the patient. It's very common. It can be after a fall, trauma, very, very common after delivery. If there's any urinary or bowel dysfunction or visceral prolapse, and then sexual dysfunction as well. All of these things are so tremendously impacted by that pelvic floor that when we can address that structural component, sometimes the benefits are actually very, very surprising. Constipation and ileus is another topic that we can address whenever we're thinking about our last technique, and we think about the typical discomfort, bloating, and nausea and vomiting. Oftentimes it'll happen if we're post-op, certain medications, as well as different lifestyle components with diet and exercise and stress. Sacroiliitis is another very common thing that we can treat with this next one. We have patients come in all the time that say they have that chronic low back pain, and oftentimes that low back pain is sciatica, whether it's sciatica or not. But a lot of times when they're really talking about true low back pain, we need to always be thinking about the sacrum, and if there's any sacroiliitis, there's a component of just degeneration, inflammatory conditions like ankylosing spondylitis, and then there's a vast number of postural considerations that can lead to strain and excessive degeneration over time of those SI joints. So we're going to be talking about some muscle energy of the sacrum. And while I will not traumatize you all in terms of reviewing the diagnosis for the sacrum, I did put together a chart here. So whether you like the graphics, you like the words, you can go through a couple of different ways to remind yourself what's going on exactly with that sacral diagnosis. So we're going to skip past that part and move into a treatment position. So if we're thinking about muscle energy, classically for a flexed or a left on left or a right on right treatment, the patient is going to be lying face down with their feet going towards the floor. We're monitoring the SI. We've got our hand on her feet. You can't see that right now, but my hand is holding her feet towards the floor. And she would provide a muscle energy effort with her feet going up towards the ceiling with you resisting that effort. So for those of you who enjoy looking at different spatial relationships, you can think about this position, and if she were actually to be rotated to her right 90 degrees, so she is sitting up, this would actually be the treatment position that you could use for someone who could not lie down. So how we would do this treatment is we would ask the patient to turn to their left. We would use our leg to brace the patient's legs and move their feet to their left. So it would be very similar to the last picture. We would always monitor if we can monitor, but then we would provide a counter force so that they can rotate their torso and their shoulder against us. And so then when you, by providing that counter force, don't allow those shoulders to turn, there will be a contributing force from the legs that will actually push into yours. So that's where you're completing your muscle energy treatment of the sacrum. And you don't have to lie them down. You don't have to change positions up and down, especially throughout your treatment, if you're treating maybe the sacrum in the middle of your treatment. So that's for a forward or flexed sacral torsion. You can also have the same thing with a extended torsion. And so here we have our patient where they're lying on their right side. So this again is the classical presentation where they're lying on the side of the axis and they're rotated the opposite direction. So again, if you sat her up, this would be a similar position. And we achieve that by having her cross her left leg over her right leg. Similar for the procedure, we would have her rotate against our hands, and she would have force coming from her legs to complete that muscle energy effort. This one's a little bit harder to monitor, but you can still monitor that dysfunctional SI joint. So for some general considerations, just with the thoracics and the lumbars, we're just going to talk briefly here. And that is really just to get some more optimization of techniques that you may already be using. And so, especially in our society today, we are on our phones a lot, we're at the computers a lot. We all tend to slouch just a little bit. And so whenever you're starting to screen your patient, you'll be ahead of the game if you just make sure that they're sitting up straight, they're in neutral, and they're not in flexion. So it helps you identify both flex and extended lesions, or type 1 with neutral dysfunction as well. The other thing is that after you've diagnosed them and you know what you're going to do, how you're going to treat them, anytime you can treat a patient where they are centered over their line of gravity, it's going to allow them to be more stable. It's going to be more ergonomically advantageous to you because you're not supporting them. You're not putting yourself at any risk of injury. And generally, because of the relaxation that's there at baseline there, you get a little bit better relaxation and more from your treatment. A lot of the techniques that we've talked about, you've seen me standing behind the patient. And that is generally where I like to be with these seated treatments. However, when the patient is sitting in the chair, they're a respiratory patient, they just got there, they've got a long way to go. I don't want to move them back to the bed just to need to get back into the chair. Or maybe you don't have somebody to help you move the patient. We can still treat them. It takes a little bit more walking from you because you need to go from one side to the other, but you can still have them move forward just slightly, not too far into flexion, but just slightly so that you can still screen and treat. Now, with that, sometimes the ergonomics are not there to be able to do your muscle energy technique. And so one brief thing that I want to mention here is the reminder of facilitated positional release. So with facilitated positional release, we're moving into ease. And so after you have your diagnosis, the 3 things that you need to remember are what I like to think about are with the 3 F's here. And so flattening the curve is what I think about instead of neutralizing the curve, so I can keep that F there for memory. So we're neutralizing that curve, we're flattening it. We're adding our activating force or our facilitating force, and we're moving into ease, or we're moving into freedom. So if I've got my diagnosis of T6 flex side bent rotated to the right, and I know that I want to use FPR just for mechanics, then I can position that patient into flattening the curve, or have them help me by sitting up nice and straight. We're trying to find that position between flexion and extension, which is a little bit hard. And so you try it. And if it doesn't get all of it with your technique, you try it again. And so you flatten that curve, you find that neutralization, you add your facilitating force, so compression or traction. Compression is probably going to be a little bit easier. And it's really just enough to get to that segment before moving into your diagnosis or your freedom of flexed side bending and rotating to the right. So it's just an alternative treatment, but it's really, really helpful in situations where maybe you can't be in the position where you need to provide a counterforce. So very, very handy and easy on you. You may also see people who will use functional, so that may be something that you're seeing a little bit more of as time goes on. It's not to be confused with functional medicine. It is actually a functional technique, probably most similar to still technique. And so we'll save that for another day. So some final tips and takeaways are really just that, you know, we're always and all on an ever-going continuum of our palpatory skills. And so taking the time to ask the question of if this responded the way it should have responded, has it responded differently than it would have previously, or has previously, or should have? And if so, why has it responded that way? If it hasn't, why has it responded that way? And you may notice a change in your thinking, and maybe helps with some diagnostic thinking and critical thinking. Any questions? I don't know that I can hear you. I'll go ahead and see if I can drop this.
There are notifications, that's why I need help about the, how to get their CME.
Okay, well, thank you very much, everyone. I love talking about OMT, so if you see me in the hall, feel free to chat, and I hope you all have a wonderful day. Thanks, bye-bye.